Welcome to our program titled AML Management Without Borders, Advancing Novel Combinations Through Academic Community Collaboration. This program is provided by Iridium Continuing Education and Global Education Group and is supported by an independent educational grant from Kura Oncology.
My name is Matt Angelos. I'm one of the leukemia faculty at the University of Colorado in Aurora, Colorado. And these here are my disclosures. So these are our learning objectives for today. All right. So just so we're all on the same page here. So AML, of course, is a blood cancer, and it arises due to an abnormal clonal expansion of myeloid lineage cells. This results in an accumulation of blasts, and then, of course, an impairment in normal endogenous hematopoiesis. There's several risk factors for developing an AML. Certainly, as patients age, they're more likely to collect mutations that can drive disease. Antecedent myelodysplastic syndromes or myeloproliferative neoplasms can also ultimately transform into an AML. And then also, exposures can play a significant role, either a previous chemo radiation from a solid tumor, a treatment, or environmental exposures like tobacco smoke, Agent Orange, certain chemicals, and pesticides. All of this can predispose individuals to getting AML. We're also learning now that germline inherited or hereditary mutations can also be a major driver for AML. And if certain ones are detected, this should prompt consideration for germline testing and a referral to a genetic counselor. These here are just common symptoms that we often find in patients presenting with AML. Predominantly fatigue, weakness, and bone pain tend to be hallmarks of this disease. And patients, of course, can have excessive bleeding, easy bruising, and then other complications like recurrent infections or sequelae from anemia. So all AML here results from the oncogenic transformation of hematopoietic stem cells or multipotent myeloid progenitors. And it's important to remember here that not all mutations, when they pop up, are actually going to be causing disease. So there are conditions that are called clonal hematopoiesis of indeterminate potential, or CHIP. These are when mutations are present, but they actually don't manifest any cytopenias or any signs or symptoms of the disease. And so these people can be monitored with serial CBCs and even consideration to getting them in to see a multidisciplinary CHIP clinic for long-term follow-up. So in the grand scheme of things, in terms of cancer diagnoses, AML continues to be a rare disease. There is only about 65,000 new cases of AML in the United States in 2025. It remains one of the more prevalent leukemias that we do see. And it oftentimes is a disease of older individuals. So the median age at diagnosis was 68, and outcomes continue to remain poor, unfortunately, with a 5-year relative survival rate about 30%. Again, as I mentioned, AML is caused by genetic mutations, and over 97% of individuals with a diagnosis of AML have an actual identifiable somatic mutation that drives their disease. Patients, of course, can have multiple driver mutations, but of course, we do at least see one of them that is disease causing. And this here on the right is just a bar representation of some of the most common mutations that we do see, many of which now we do have targeted options available for. So FLT3 is one predominant mutation that we often see with regularity. It's important to note there are two flavors of this mutation. There's an internal tandem duplication, an ITD mutation, and then also a tyrosine kinase domain mutation, a TKD mutation. And this is important because certain FLT3 inhibitors are only active against certain types of the FLT3 mutation. We also see with regularity NPM1 mutations, IDH1 and 2, and then some of these more adverse risk mutations like TP53, and then also NRAS and KRAS mutations. The genetic profile of the AML is extremely important in the year 2025 because we really now use it as a metric to have a discussion about a patient's prognosis, their relative risk for relapse, their responses to chemotherapy treatment, and then also nowadays, what initial treatment we're going to offer the patient. These AML mutations, they can affect multiple different aspects of hematopoietic stem cell self-renewal. Some of these mutational drivers can affect genomic stability and also DNA methylation. They can also affect protein cell signaling that's mediated by tyrosine kinases, transcriptional activation, how DNA is processed and modified. All of these specific mutations and their biological mechanisms of action are listed here on this slide for your reference. So again, the initial genetics at the time of an AML diagnosis really do serve an important role for risk stratification. There are a number of different risk stratification classifiers that are out there. However, the most accepted one in our field that we use is the European Leukemia Net, or ELN 2022 criteria. And all of this is summarized here on this slide. The most important one to be at least familiar with here is the favorable risk classifier. This will certainly inform initial therapy selection for patients. And we consider favorable risk AMLs to be core binding factor mutated AML, either translocation 821 or RUNX1, RUNX1T1, or inversion 16, which is core binding factor B, MYH11. Patients can also have mutated NPM1 without a FLT3 ITD mutation, and also now a mutation specifically within this gene CEBP alpha, with the caveat that it has to be an in-frame mutation, specifically within the C-terminal BZIP domain. Patients that have favorable risk AML here are generally considered to be chemotherapy sensitive, and we oftentimes think we can cure them with a chemotherapy approach alone without a consolidative allogeneic stem cell transplant. 5-year overall survival rates are approximately 55% in this risk group. And of course, the outcomes are worsened as patients have higher risk mutations that comprise the intermediate and adverse ELN 2020 risk stratifiers. Like I said before, we're starting to learn more about these germline myeloid mutations that possess a predisposition to developing a myeloid neoplasm in the patient's lifetime. We do know quite a bit about these classic genes that cause hereditary syndromes like RUNX1, DDX41, GATA2, TB53. But now we're starting to see other mutations playing a role in this hereditary fashion, such as MSH6, BRCA1, and then also CHEK2. So again, if you identify these types of mutations on somatic NGS testing, it should really set off some alarm bells that we should be following this up with dedicated germline testing. This would have a potential impact in choosing specific family members to be a donor for an allogeneic stem cell transplant, as well as also just screening and surveillance of other family members for the development of a myeloid neoplasm down the road. So this slide here demonstrates some of the initial testing that we will do to make a diagnosis of AML. And what's important here is that we really do need all of these components in order to make a comprehensive diagnosis with the appropriate risk stratification. So of course, all patients really do need to have a bone marrow assessment. This includes a bone marrow core biopsy, as well as an aspirate if this is able to be obtained. A diagnosis of AML, of course, is made when there's greater than 20% myeloblasts that are present, or it could be made when there's less than 20% in the presence of an AML-defining mutation, mutations like core binding factor or NPM1. This is not a focus of today's talk, but there are newer classifiers that are coming out, being published by WHO and ICC, that have liberalized the definition of what an AML actually is. And so it allows us to diagnose AML at a lower blast percentage. And this allows us then to offer patients treatments along an AML paradigm a lot sooner, with the goal of trying to prevent full-blown disease and even just aggressive transformation into ultimately an AML. Immunophenotyping is also important. We're learning that certain flavors of AML confirm resistance to certain therapies. And so it's always informative to know what the immunophenotype is up front. And then again, molecular genetics and cytogenetics, testing such as PCR and NGS, as well as FISH and karyotype analysis, are also still informative in 2025 and are needed to appropriately risk stratify patients. So again, these are all just the standard of care tests that should be sent on all newly diagnosed AML patients. What's important to also remind folks of here is that in the event that bone marrow aspiration is unable to be obtained or is not adequate, some of this testing can be run off of the peripheral blood, specifically NGS, as it has a pretty high level of sensitivity for looking for somatic mutations. But other tests such as karyotypic analysis, as well as FISH testing, are really only best served when there's a high percentage of circulating blasts present. In terms of the types of testing that we use, it's important to remember that there's various levels of sensitivity for each of these tests. And this is particularly important when we're starting to consider the definition of this type of remission that we hope to get patients into, which is called a MRD negative remission. So MRD refers to measurable residual disease. And again, depending on the type of testing you use, this is going to gate insight onto the level of any potential leukemia that might still be remaining. So, quantitative PCR, and now more specifically, digital droplet PCR, offers one of the highest levels of sensitivity with a pretty good level of reliability. It's a useful test specifically when there are targeted probes available that are validated for a particular mutation. And we oftentimes will have this available for mutations like core binding factor, NPM1, and also IDH1 and 2. Multi-parameter flow cytometry is sensitive on the order to about 10 to the minus 3, 10 to the minus 4. This generally is a universal standard for MRD in the absence of any identifiable mutations. However, there's a caveat that it's somewhat operator dependent. It depends upon the panel that's used, and there can be discrepancies depending on where the test is sent and how a hematopathologist analyzes the flow cytometry reports. GS testing, on the other hand, while it can pick up a lot of these AML driving mutations, does have a variable level of sensitivity, and it can be relatively nonspecific with depth of detection only as little as 10 to the minus 2. So because of this, and because it's not been standardized, it has not been routinely accepted as a good test in order to discern whether or not there is MRD present or not. In terms of MRD, this obviously has important prognostic pieces of information that we use to make clinical decisions. And the NCCN has recently put together some guidance here on the types of MRD methods we should be using, as well as the frequency of testing for MRD level disease. It's important to make sure that you do collect at diagnosis the MRD test that you were going to then follow the clones throughout a patient's leukemic course with. And in general here, it's generally recommended that MRD testing should be pursued at least after cycle 1 or cycle 2 of treatment to discern whether that treatment is actually working and effective for that individual. And then, of course, at either end of treatment or immediately performing an allogeneic stem cell transplant to consolidate a patient's remission. So in terms of the actual first-line treatments that we use, again, the key takeaway message here is that it's really important to appropriately risk stratify patients to choose the correct therapy. So in general, if patients are considered to be eligible and we think the AML is biologically appropriate for high-intensity induction, then a regimen like 7+3, which is cytarabine in combination with an anthracycline, is still routinely offered. Specifically, if a patient has a core binding factor mutation present, then gemtuzumab ozogamicin, which is an anti-CD33 antibody drug conjugate, should be added to the backbone of 7+3. And this was driven by data that came out of a meta-analysis of the initial gemtuzumab clinical trials that demonstrated an overall survival benefit in patients that had core binding factor AML, so long as their disease was CD33 positive. If a patient has a FLT3 mutation, the standard of care is to incorporate a FLT3 inhibitor, either midostaurin for ITD or TKD mutated AML, or also even now considering quizartinib only for patients that have a FLT3 ITD mutation. The drug is not biologically active in FLT3 TKD mutated cases. In individuals that are a little bit older and still thought to be eligible for a high-intensity induction over the age of 60 and have a prior MDS or a therapy-related AML, then consideration could be given to CPX-351 or Vyxeos. This is a liposomal cytarabine and daunorubicin combination similar to the 7+3 regimen that does have a little bit less toxicity as compared to the standard 7+3, also an appropriate option. So generally, when we decide on a high-intensity induction method, we see if it's working by pursuing a day 14 marrow with the goal of having a myeloablation. And then at the time of count recovery, often between days 35 and 42, we do assess for overall disease response and whether or not a patient is truly in a complete remission or not. Thereafter, patients have to have some sort of consolidative therapy. This can either be in the form of additional curative intent chemotherapy, for which options are shown here, or by pursuing an allogeneic stem cell transplant. In general, allotransplant should be considered for patients that have, per ELN 2022, either intermediate or adverse risk AML. This slide here is just a summary of what I went over. Again, very importantly, making sure you appropriately risk stratify patients in offering them the correct induction chemotherapy. Now, in terms of adverse risk disease, specifically TP53 mutated AML, unfortunately, we are learning that there is no really great standard of care first-line therapy that should be chosen. A TP53 mutated disease oftentimes confers a poor prognosis and has resistance to conventional chemotherapy. So generally, when I have a patient that has a new diagnosis, TP53 mutated AML, I am oftentimes thinking about whether or not there is some sort of investigational clinical trial that they could be enrolled on, either with a backbone of standard of care treatments with the new agent or as just the new agent alone with other options. Generally, though, if they are not considered fit enough to get high intensity chemo, or if potentially they might even be a borderline candidate or younger, we will oftentimes default to lower intensity azacitidine venetoclax treatments, given comparable CR rates and relatively lower toxicity with those regimens. So what are some of these novel therapies here? So these are all listed here on the slide. Over the last 10 years or so, we've had about 11 or 12 now new FDA approved targeted drugs that have been added to our armamentarium for AML. I do want to highlight here what's not on this slide is that revumenib, which is a drug that's a menin inhibitor, is now FDA approved here for individuals that have KMT2A rearranged AML. And then very excitingly, this past month, we now have an FDA approval for ziftomenib for individuals that have an NPM1 mutation. So as a reminder here, the original targeted therapy was venetoclax here in the last 15 years. This is a drug that targets BCL2, which is an anti-apoptotic protein. This was validated here in the phase 3 registrational VALIA study. It was a 2-to-1 randomization in individuals that were older than 75 or were younger than 75 that had comorbidities that prevented them from getting high-intensity chemotherapy. And as you can appreciate here from the survival curves, those that got Aza-Ven had a median overall survival around 15, which was markedly improved from those that just received azacitidine and placebo, median OS between about 10 and 12 months. There was a tandem similar trial that was done concurrently that instead of using azacitidine, looked at LDAC, again showed a survival advantage with the combination of venetoclax as compared to individuals that just received LDAC and placebo. So this turned into a standard of care and was the backbone for now lower intensity approaches that we routinely use. Now, in terms of side effects for this, it's important to remember that patients can develop something called tumor lysis syndrome. It's not the majority of patients, but certainly as patients get higher disease burden or even circulating disease, they are at risk for this happening. This is why we oftentimes, or in all times, actually would ramp up venetoclax over the course of 3 days prior to getting to steady state dosing. And this has to be monitored for either in the inpatient setting or with very close follow-up in the outpatient setting. Cytopenias are also a issue that we run into with combination HMA venetoclax. Oftentimes, what I will still do in my practice is give patients a full cycle of an HMA with venetoclax for 28 days. We will restage the disease to see if patients are in a remission or not. And if they're in a good CR, ideally an MRD negative CR, we will start to drop down the total number of days, not the doses, but the days of venetoclax that's given in a way to try to mitigate ongoing cytopenias that can obviously cause issues like bleeding and then also increased incidence of infection. Ivosidenib was another targeted therapy that was studied in trial in the late 2010s, early 2020s. It first initially was studied as a monotherapy in patients that had relapsed refractory AML, specifically with IDH mutations. And so in these initial trials here, again, patients with really no other good options that were not eligible for high intensity chemo still were getting CR/CRh rates on the order of about 20 to 30%. And if you looked at a study that was done here for folks that were not eligible for high intensity chemotherapy and only received ivosidenib as monotherapy, relatively decent median overall survival on the order here of about 10 to 12 months, again, just with single agent IVO alone. What's important to keep in mind here is that these drugs are not totally benign. There are some side effects that have to be monitored for and looked after. Two of the main ones here for these IDH inhibitors include QTC prolongation and then also differentiation syndrome. So in my practice, I am checking EKGs prior to administering the drug, ideally having their QTC less than 480 milliseconds before starting, and then doing a check-in at least 1 week after starting the drug to make sure that this interval is not getting too long. But differentiation syndrome is in fact a real thing that can happen. It's a little bit different than what we see with giving patients ATRA for APL. It tends to happen a little bit more delayed. It can be weeks to actually after starting the ivosidenib or enasidenib that you can start to see differentiation syndrome. But if you see a patient that you start on the targeted therapy and they develop any number of these constellation of symptoms, you should have a low threshold here for pausing the drug and then also starting steroids in order to reverse this. Now, in terms of FLT3 inhibitors here, midostaurin was kind of the original FLT3 inhibitor that was studied now over 10 years ago. In fact, they reported 10-year follow-up at ASH last year. This randomized 800 patients to receive high-intensity chemotherapy with or without midostaurin. And here, again, compared to placebo here, marked improvement in overall survival and also event-free survival, which then allowed midostaurin to become a standard of care in combination with high-intensity chemotherapy for FLT3 mutated AML. Now, what about thinking about FLT3 inhibition even after first-line treatment? There was a newer drug that came out to market called gilteritinib that was initially studied in the relapse refractory setting and showed a benefit for patients that otherwise had no other options for their FLT3 mutated AML. And so the question became, could we utilize gilteritinib as a potential maintenance strategy for patients that had actually undergone an allogeneic stem cell transplant? So this was a randomized phase 3 study that was run from the BMT CTN. And the question was whether or not we should be giving patients gilteritinib 2 years after their transplant in order to prevent relapse and ultimately to really minimize any adverse events that would pop up. And so the primary endpoint for this study was relapse-free survival, not overall survival, but relapse-free survival. And they found here that in individuals or all comers that got gilteritinib after their transplant, there was no statistically significant benefit to giving gilteritinib. It just missed meeting significance. However, if you looked at individuals that were MRD positive prior to getting a transplant, there actually was a statistically significant benefit in terms of relapse-free survival for continuing the gilt 2 years after transplant. A caveat to this is that this was a highly sensitive MRD level test that was used. It detected disease to 10 to the minus 6. But nonetheless, we do send this out. It's a test that's offered by In Vivo Scribe. And if it's positive prior to going to transplant, I think the data is pretty clear that they should be offered post-transplant maintenance with gilteritinib for up to 2 years. FLT3 inhibitors, like IDH inhibitors, can also have adverse events that can pop up here. Some of the main ones that are important to note here revolve around quizartinib. A QTC prolongation is obviously an important factor we watch out for. This has a black box warning in terms of making sure the QTC is appropriate, less than 450 prior to starting the drug. And this is something that I often will check in patients that do start a FLT3 inhibitor to make sure that this does not get too prolonged. Gilteritinib very rarely can cause a differentiation syndrome. We don't oftentimes see this, but this is also an important consideration to remember for that drug. I think in the interest of time, I'm going to skip over some of the data with the gemtuzumab in the upfront setting. The AGILE study was a study that was a randomized phase 3 study that looked at combination azacitidine with ivosidenib to target IDH1 mutated AML. And what I like about this study here is that it demonstrated in combination that Ivo-Aza was relatively tolerable and led to a median overall survival that was just about on par, maybe just a little bit better than what we see with Aza-Ven combination. So I oftentimes will reserve ivosidenib with azacitidine for those older and maybe frailer patients that we might think will have an issue with giving them a little bit slightly more intensive venetoclax-based therapy and some of the side effects that go along with that. So where we're at now is the field is really moving towards thinking about trying to combine all of these things together in triplet combinations. I will say here that we have probably the most robust data looking at lower intensity azacitidine with venetoclax, that backbone in combination with FLT3 inhibitors. Gilteritinib has been the one that's been most matured and has published phase 1, phase 2 data with now ongoing phase 3 studies that are enrolling. But we are now also entering this era, not listed here on this slide, of starting to combine menin inhibitors as well to backbones of high intensity chemotherapy and now also lower intensity chemotherapy. And so that data is now just starting to get published, reflecting results from phase 1, phase 2 clinical trials. I think we talked about side effects already. And again, what I really want to impart here is that, we have to really decide what type of treatment makes the most sense for an individual patient. So obviously patients that are going to be a little bit more on the older side, a little bit more on the frailer side, we probably don't need to be giving these folks a high intensity chemotherapy for all AML disease indications. It would make a lot more sense if we biologically looked at what their molecular characteristics are and choosing perhaps lower intensity treatments with something that might be a little bit more targetable. Let me just go over one example here of perhaps a common scenario that we would see in our practice here. And really the question is, what should we do for initial treatment for this patient? So we have limited information about this patient here, but this is Mr. Johnson. He's 72 years of age, presumably has a diagnosis of AML. And on next generation sequencing, we found here mutations in 3 genes. Conveniently enough, we have targeted options available for all of them, including NPM1 mutation, IDH2, and then also FLT3 ITD. And so the question is, what exactly should we choose? And so I think for an individual like this, I think the number one thing that you have to consider here is what is the general performance status of this patient? And is this somebody you think would be eligible for and would be interested in pursuing an allogeneic stem cell transplant? So by the ELN risk classifiers here, due to the presence of a FLT3 ITD mutation, he is technically stratified here towards an intermediate risk disease, even though NPM1 mutations are favorable risk mutations. And so for individuals like this, an allogeneic stem cell transplant should be considered. And so, in my mind, I know that outcomes for a transplant are markedly improved in terms of overall survival when patients are in an MRD negative state prior to pursuing an allogeneic stem cell transplant. So this would be an individual where I would really like to get him into an MRD negative remission prior to pursuing his allo, only because I know the risk of a relapse is markedly reduced after transplant when patients are MRD negative going into it. So for this individual here, I'm being 72, a little bit on the older side, again, intermediate risk. I think this would be somebody that I would ultimately choose to do azacitidine and venetoclax in, particularly as this individual is going to be moving towards a stem cell transplant anyway. And so the question is, should we add something else up front? And so again, we have 3 options that are available. In my opinion, I think the most robust and most validated data revolve around the FLT3 inhibition. There have been now some earlier phase 1/2 studies that have been published that have looked at the addition of gilteritinib in combination with azacitidine and venetoclax. And in individuals that get triplet therapy up front, the rates of remission can be quite high. It can actually exceed 80%. And this, is somewhat, a little bit better than what we saw on the registrational BALE-A study. However, again, no phase 3 randomized data that are available yet, single center studies that have mostly been published. And what I will say is if you just look at the subgroup analysis from BALE-A, folks that had a FLT3 ITD mutation had CRs somewhere on the order of about 65, 70%. And so the question is, are you really getting that much benefit from adding in FLT3 at cycle 1? In my opinion, probably not. Probably giving these people a little bit more potential toxicity due to the fact that they have triplet therapy, a little bit more cytopenias, a little bit difficult to get to count recovery, and then proceed with more chemotherapy if not in an MRD negative remission. And so for this individual, what I would propose is we would start here with one cycle of aza-ven, see if they're in an MRD negative remission. And if they're not quite there at the end of cycle one, if they're doing well and they've had adequate count recovery, I would likely propose adding in gilteritinib as a triplet therapy for cycle two, just to see if we can get them into an MRD negative state prior to their transplant. I think the verdict's still out here about NPM1 triplet combinations. The early data that's come out with the triplet trials with both revumenib and ziftomenib look quite encouraging, with responses potentially even exceeding 90% CR with triplet combination. However, I think this is just not just quite ready for prime time. However, not a totally inappropriate choice to consider a menin inhibitor in these situations. What I would also comment about this case is that it really, you know, should be thoughtfully looked at what the percentage of these mutations are. So, for example, if a patient has a FLT3 ITD mutation that maybe is really low level, something like 2 to 3%, but maybe has an NPM1 mutation with a VAF of something like 60, 70%, it might be a little bit better bang for the buck to give menin inhibitors to target the NPM1 as compared to the FLT3. Same thing, other way around. If FLT3 was predominant, definitely favoring a FLT3 inhibitor in these situations. So I don't think any of these options are wrong. I think the goal for a patient like this, if they're a candidate for a transplant, should really be trying to safely get them into an MRD negative remission in order to optimize their outcome from a transplant. We're really now needing a full comprehensive set of both genomic and molecular data in order to adequately make a diagnosis of AML and then appropriately risk stratify patients and then select the appropriate first line course of therapy. So, at most institutions here, I think we can get all of these pieces of information back within at least a week from when we do their diagnostic bone marrow. And as a reminder here, it's important that we're able to get good morphological assessment by a hematopathologist in order to make a diagnosis of AML. Again, this diagnosis is made when morphologically blasts, myeloblasts specifically in the marrow, are greater than 20%. Or you can have situations now where the blast number may be less than 20%, but there is a presence of an AML defining mutation, things like core binding factor, PM1, and a variety of others. Immunophenotyping or flow cytometry often can come back relatively quickly within 48 hours at most centers. Very important in order to determine the flavor of AML that we're dealing with, because certain types of AML respond differently to standard of care treatments, specifically venetoclax, which we'll talk about in a second, and again, can be very informative for making a treatment selection. A couple of days later, we oftentimes will get other molecular and genetic pieces of information that's used to make a clinical decision. These include specific tests, including PCR analysis, as well as next generation sequencing for specific mutations. And then, of course, cytogenetics, both FISH analysis as well as karyotype, which often will result a little bit later, but nonetheless very important to make a diagnosis and then a clinical decision. Again, just as a reminder, these are all the appropriate tests that we will order. Generally, we try to get these off of a bone marrow core and aspirate. However, in some cases where an aspirate or core is not able to be obtained, we can run some of these tests off the peripheral blood. Generally, flow cytometry and NGS testing tend to be reliable tests, whereas others such as FISH and karyotypic analyses begin to become less sensitive once the circulating blast percentage really gets below 10% or so. So in terms of how we actually, we treat a patient, how do we actually define whether or not they're in a remission? What we usually depend on now is guidance from the most updated European Leukemia Net criteria, which was published back in 2022, which defines basically all of the different states of remission. And a lot of this is somewhat academic. We definitely rely on many of these definitions for clinical trial purposes, but nonetheless can be, very important to document correctly and then ultimately decide, whether or not you need to move forward with an ancillary line of treatment if patients are not quite in a complete remission. So really the key takeaway message from this slide for everyone to be aware about is that there are various depths of remission. And kind of the most superficial layer of remission is this concept called morphological remission. We'll abbreviate this lowercase m, capital CR. This is defined by blasts that are within the bone marrow less than 5%. And then also an absence of any circulating disease or extramedullary disease, as well as healthy, normal hematopoiesis, which is indicated here by an ANC greater than 1,000, and then also platelets over 100. We have various classifiers in case the hematological recovery is not up to snuff. We call these things partial hematological recovery or incomplete hematological recovery. There's some other flavors that we also use for trial purposes, but really morphological CR is really the key benchmark we want to get into. It's also very important now to consider MRD negativity. And what MRD stands for is measurable residual disease. And so, what we're really trying to test here is whether or not we can find even the most microscopic levels of leukemia that potentially could be sticking around after treatment that might not be detected morphologically on a bone marrow core by a hematopathologist. And so, in some situations, what we might see is that all of the disease is cleared out by eye under the microscope, but we may have these very small subsets of leukemic clones that are really only detected by doing multi-parameter flow cytometry or also genomic testing if you have a specific gene mutation that you can go after. And so, this has really important clinical implications. What I really want to impart on everybody here is that it is better, as one would stand to reason, if patients have no detectable disease whatsoever, this concept called MRD negative, as compared to if patients maybe are in a morphological remission, less than 5% blasts, but might have some microscopic disease still sticking around. These would be MRD positive individuals. This is particularly important when you're considering consolidating somebody's remission with an allogeneic stem cell transplant. The data is very clear if patients are MRD negative going into a bone marrow transplant, specifically if they are older and you're pursuing reduced intensity conditioning approaches, those outcomes are markedly better in terms of overall survival as compared to if patients are MRD positive going into their transplant. Now, you have to be a little careful on how you define MRD. MRD is not standardized across our field quite yet. There are many different techniques and modalities that are used with different levels or different depths of sensitivity. But as a general concept, our field does typically consider at least flow cytometric analysis, multicolor flow, or send out flow to a standardized facility to really be the gold standard on whether or not they're MRD positive or negative. In some situations, we can utilize genomic testing like PCR in order to look for even smaller amounts of mutations that still may be present, but those are select cases that are dependent on whether or not there's a targetable mutation to actually test. We went over this last time, but again, multiple different modalities for MRD testing. Quantitative PCR, or nowadays we use digital droplet PCR that has even greater sensitivity, really can detect leukemic cells all the way down to the order of 10 to the minus fifth. Multicolor flow is generally on the order of 10 to the minus 3, 10 to the minus 4. And NGS testing, even though it can pick up a large number of mutations, can actually be less sensitive than other MRD assays. And so as of right now, the field does not generally consider NGS to be a standard for MRD level detection, but nonetheless is an important adjunct in making diagnostic decisions about leukemia and then also initial treatments. We went through this last time, but we also monitor MRD at various points of treatment. The key takeaway message here is that you do have to make sure you send off at diagnosis the appropriate MRD tests that you then want to trend as a function of time once patients are treated. If you don't really have this baseline, it becomes very difficult to interpret the mid cycles and then the pre-transplant MRD status. All right, so moving here into relapsed refractory AML here. Again, this is classifiers that are based upon the 2022 ELN definitions. This comes out of a manuscript that was published by Dr. Donner. This was published in Blood, and so this is easily acceptable and accessible and is something we quite often use for clinical trial purposes to determine what type of depth of remissions patients are, and then also whether or not patients have refractory disease, which is a failure to achieve a complete remission, or if they have relapse disease, which is disease that comes back after a patient has had documented evidence of some type of CR. Same thing here for MRD relapse. Patients have to be MRD negative first and then flip over to being MRD positive in order to say that they have an MRD positive relapse. And so again, very important you're choosing the right MRD level test in order to make that conclusion. So we went through this last time. This is, again, just the NCCN recommendations here for induction and then consolidation. As a reminder here, the key parts are that you really have to be able to discern whether or not a patient has favorable risk cytogenetics per 2022 criteria. As a reminder here, favorable genetics consist of core binding factor, either translocation 821 or inversion 16, as well as individuals that have an NPM1 mutation with wild type FLT3 status, as well as individuals here that specifically have a CEBP alpha mutation that's an in-frame mutation, either insertion or deletion, specifically within the C-terminal BZIP domain. If they're not favorable, it is likely that they are not going to be cured with high intensity or low intensity chemotherapy alone. And these such individuals should have a strong consideration for consolidating their remission with an allogeneic stem cell transplant. We talked about last time that there are various other combinations of targeted agents that we can add into high intensity chemotherapy for first line induction, specifically if patients have a FLT3 mutation at the time of diagnosis. As a standard of care, we are including a FLT3 inhibitor that can either be midostaurin, gilteritinib, or quizartinib. This here is, again, NCCN recommendations, but now thinking about this in the relapse refractory setting. And what you can appreciate from this slide here is that all of the agents here are all targeted therapies that specifically go after a mutation if it's present. So for example, if patients have FLT3 ITD, options include putting them on single agent gilteritinib. What we don't really use in the United States, more older school flavors of FLT3 inhibitors like sorafenib in combination with hypomethylating agents. Again, IDH1, IDH2 inhibitors play a very important role if these mutations are present. And if patients are CD33 positive, there is a consideration for potentially challenging a patient with gemtuzumab ozogamicin. This is an anti-CD33 antibody drug conjugate that is approved in the relapse refractory setting, but also something we use in the upfront setting for individuals that have core binding factor AML. If patients are really quite ill and they can't get any other intensive chemotherapies, again, very similar targeted therapies tend to be quite effective. I do want to introduce here that we now have some new drugs which are called menin inhibitors that we'll get into in a second. These are drugs that are effective for individuals that specifically have a KMT2A rearrangement. Generally, this involves translocation involving part of the arm of chromosome 11 or NPM1 mutations. And so we have revumenib, and now as of last month, ziftomenib, that are FDA approved for KMT2 rearrangements and also NPM1. I do want to highlight here this TP53 line here. This is magrolimab. This is an anti-CD47 antibody. This actually failed to show any benefit in a phase 3 clinical trial, and this is actually not approved for relapse refractory TP53 mutated AML. All right, so I do want to spend just a little bit of time here talking about salvage chemotherapy regimens for patients. And, the short answer to this is that there is no one regimen that shows superiority over any other salvage chemotherapy regimen in relapsed refractory AML. It essentially turns into dealer's choice. And what I really want to just impart to everybody is that you shouldn't be looking at the NCCN guidelines and just kind of going 1, 2, 3, 4, 5, thinking that this is the option of salvage treatments that we should be doing. You really have to kind of use your brain and think about it biologically to think whether a salvage combination here is going to be effective in the context of what patients had already received. So, for example, if patients have received 7+3 and are refractory with residual disease at the end of induction, it really doesn't make a lot of sense to then give them something like CPX 351, which is liposomal daunorubicin cytarabine. It's basically kind of the safer version of high-intensity chemotherapy. Similarly, if patients start out with maybe even a higher intensive regimen like FLAG-IDA, it doesn't really make sense to then follow up a refractory disease situation with standard of care 7+3. So some thought should be given to the salvage regimen. And in my opinion, it's always best to try to choose drugs that have different mechanisms of action than what they have already seen and what they're already refractory to. What I also want to highlight here is getting some growing evidence in our field for relatively high degrees of efficacy are cladribine-based regimens. So there are a couple of different regimens out there, one of which is called CLIA, which is cladribine, idarubicin, and cytarabine. Another one is one that we use now with quite regularity with patients that have venetoclax refractory disease, which is a combination of cladribine, again, venetoclax, and also low-dose cytarabine or LDAC. But the data that's been coming out of the phase 1/2 studies from the MD Anderson group have really suggested that patients, even with refractory or relapsed disease, have relatively good percentages in getting back into a remission with the cladribine-based approach. So we're starting to use more and more of these treatments. They're basically deviations or variations of this CLAG-based regimen that the Fred Hutch group actually does quite use a lot of. And we're finding it to be particularly effective for those that maybe are not responsive to venetoclax-based therapies. Again, if patients are not eligible for these higher intensity treatments, unfortunately, it's really kind of slim pickings moving forward on what we can give them. It is possible you can consider single agent gemtuzumab. There's also technically an FDA approval and in the NCCN guidelines to give a combination, which is called a hedgehog inhibitor called galastagib in combination with low-dose cytarabine. Unfortunately, the reality is that the rates of remission for both of these strategies are quite low, generally less than 20%. But if patients are interested in something, that would be a reasonable standard of care option to go after. I would say in situations like these, high emphasis for trying to get patients to a tertiary academic center, and then strong consideration for putting them on novel agents, novel investigational agents as a part of a clinical trial. Fortunately, TP53 has been a tough nut to crack. We've had a variety of different immunotherapies that we thought perhaps are going to show benefits as compared to standard of care options. None of them have really come to fruition yet from randomized trials. And so again, if you have a patient with TP53 mutated AML, it's always best to refer them to a tertiary center for consideration of novel agents. My personal opinion is that I think either TP53 direct targeted agents or immuno or cellular therapies are probably the way to go, as TP53 is a tumor suppressor gene and generally quite difficult to treat once a mutation is identified. So I think out of all of this here, these are, I think, good guidelines to go after here in trying to choose the right treatment strategy, particularly for those that have relapsed refractory disease. Obviously, relapsed refractory AML is a high cause of mortality. It's very important to consider the age and the fitness and the performance status of your patient and have a good understanding of what the side effect profiles are, because again, difficult to treat relapsed refractory AML, likely not to be curative. We really do want to try to maximize patients' quality of life, knowing that patients generally have poor outcomes at this point. Goals of care should really be established early in order to identify the best treatment for each patient. And I would also say if you might have an individual that has low level disease burden and they're fit and they're healthy, it's not an unreasonable thing to do to be aggressive with their salvage treatment, with the ultimate goal of trying to get them to a potentially curative allogeneic stem cell transplant. The way that we do transplant now, we can do transplant quite successfully and quite well to individuals all the way up to the age of 80. So I do want to impart here that age should not be a barrier in considering allogeneic stem cell transplant. And getting these patients plugged into a tertiary center that does high volume and high risk transplants early on at the time of their diagnosis is always advantageous to these patients, because we know the sooner that we do transplant when patients are fitter and healthier, the better their outcomes actually are. All right, so this is a slide I showed on Monday. Again, this goes over all of the menu of options that we have available for targeted therapies for each specific mutation that may be present. Again, I want to highlight here that for NPM1 mutated disease, we do now have menin inhibitors, both revumenib, which is not on this slide, but also ziftomenib that just got recently approved last month. The same thing here for KMT2A rearrangements, where we have revumenib as an option for these patients. Again, IDH1, IDH2 inhibitors, FLT3 inhibitors as well. And then really, again, the original targeted therapy that's now been approved for several years is venetoclax. So again, in my opinion, I think all patients should at least be challenged if they're able to receive chemotherapy with lower intensity hypomethylating agents with venetoclax combinations. Again, from the registrational VALIA study, there was a benefit in overall survival in adding venetoclax, both on the backbone of azacitidine and then also on the backbone of low-dose cytarabine. We talked about this last time, but there can be, again, side effects that are associated with venetoclax specifically. The main one that we worry about is tumor lysis syndrome. This is death of leukemic blasts that result in electrolyte imbalances and potentially kidney dysfunction. That really does have to be monitored quite closely, either outpatient or inpatient for older and frailer individuals. Ivosidenib is a IDH1 targeting oral small molecule drug, initially got approval for relapsed refractory IDH1 mutated AML. And again, patients that failed standard of care therapies really didn't have any other options available to them. On single agent ivosidenib, we're getting CR rates on the order of about 25-30%. And this one slide here is the data from the newly diagnosed cohort, which is single agent ivosidenib. But you can appreciate here that overall survival can really actually be on the order of about a year or so just with this one targeted drug. There's been another kid on the block here, which is called olutasidenib, that was investigated here and published in 2023. A newer flavor of ivosidenib. The mechanistic properties of olutasidenib are just a little bit different from ivosidenib in that the way it binds the IDH protein specifically and the way that it locks in the conformation of the protein. And it's hypothesized here that it might be a little bit more of a potent drug as compared to ivosidenib. But I would just say from the trials that have been published looking at this in the relapse refractory setting, overall, it looks like outcomes are relatively similar. So generally in my practice, just because ivosidenib has been around a little bit longer, there's a little bit more robustness to the data that's available. And then also we know how to deal with the approvals and the insurance companies to get the drug for our patients. I generally do reach for ivosidenib first. However, if you do have a patient that is refractory to IDH1 or maybe acquired a mutation, a new IDH1 mutation or SNP, it would be a reasonable strategy to then switch them over to olutasidenib and see if you can perhaps regain anti-leukemic activity. Enasidenib here, this is for relapsed refractory IDH2 mutated AML. This here is the data that was initially published in the phase 1/2 study that enrolled about 239 patients. 170 of these people had relapsed refractory IDH2 mutated AML, heavily pretreated patients with either induction or Aza-Ven. And you can see here that the median overall survival for patients that got single agent enasidenib was on the order of about 9 months. So again, it is a strategy where we can potentially prolong life, and it would be, somewhat a relatively good quality of life because this is a pill. Perhaps trips to the infusion center and blood work are reduced, and it's generally a well-tolerated therapy for patients. It is important to remember that there can be side effects that are related to these IDH inhibitors, and the key ones to take home here are specifically differentiation syndrome. And in the case more so for ivosidenib than enasidenib, is this concept here of QTc interval prolongation, and then more so here for olutasidenib, but we can see it as a class effect, is hepatotoxicity. And it mainly manifests as asymptomatic hyperbilirubinemia. The numbers can get quite large, up into like the 20s or so. But generally, when the drug is held, weeks will go by, and then the bilirubin will ultimately start to normalize. Differentiation syndrome is a real thing. It is a little bit different than the differentiation syndrome that we see when giving a drug like Atra for APL. It can really pop up at any time after starting the IDH inhibitor. The median time is on the order of about 3 weeks or so, maybe even longer. And so it's not surprising sometimes where we sometimes start patients on the IDH1 inhibitor, and we're talking about starting their second cycle of treatment. And this is where they come in with dyspnea, fevers, weight gain, other issues that we associate with differentiation syndrome. And these people should really be promptly recognized, treated with steroids, and consideration for holding the drug. Now, quizartinib, we can use this in the relapse refractory setting for FLT3 ITD mutated AML. Does not technically have an FDA label for this, but it has been predominantly studied here in combination with high intensity chemotherapy as well as Ven/Aza. So this slide here is demonstrating data here from the Quantum First study. And so this was a randomized phase 3 trial that looked at the addition of quizartinib here, which is in the purple, to the backbone of 7+3 as compared to 7+3 alone. And as you can see here, there was an overall survival benefit that was statistically significant for patients that received quizartinib as compared to patients that did not get it when they had FLT3 positive disease. So what's really important about quizartinib is that you can only really use this for FLT3 ITD mutated AML. There is no biological activity for this drug where it binds to the TKD mutated flavors of this mutation. And so it's really important to make sure that you recognize the right type of FLT3 mutation that's present. Gilteritinib, however, can be used for FLT3 ITD and TKD mutated AML. These are results here from the Admiral study. This was the phase 3 study run by Sasha Pearl that looked at single agent gilteritinib versus salvage chemotherapy in the relapsed refractory setting. And as you can see here, that there was an increased number of individuals that were able to get into a CR as compared to high intensity chemotherapy. And this correlated here with a statistically significant improvement in the median overall survival on the order of about 9 months. We now use gilteritinib also in the post-transplant setting. We talked about this last time, which was the Morpho study published by Mark Levis. Again, as a reminder here, there is an advantage to giving gilteritinib after a transplant only if patients were MRD positive going into transplant. And I do want to highlight that the type of MRD test here done was quite sensitive. It was a hybrid PCR NGS test that was able to detect FLT3 all the way down to the level of 10 to the minus 6. So if it's present, it is beneficial to get patients back on gilteritinib after their transplant. We talked about this last time, but again, there are various side effects associated with these FLT3 inhibitors. QTC prolongation, specifically with quizartinib, is an important one to be aware of. There's a black box warning for this on the label. And these have to, for sure, be checked before starting quizartinib and then shortly thereafter starting therapy. And then I oftentimes will monitor this on at least a weekly basis to start to make sure we're not seeing prolongation of the QTC. Gilteritinib can very rarely cause a differentiation syndrome to occur. This is quite rare. It's on the order of about maybe 4 or 5% of patients that get started on gilteritinib, but nonetheless an important thing to keep in the back of your mind, particularly if patients start to become quite symptomatic and ill after starting gilt therapy. And so just to wrap up here, I think this is the last slide I have. Again, we have these novel agents that are coming to market. So, I think the one I really wanted to highlight here was ziftomenib. This is the one that got FDA approval a couple of weeks ago, actually at the end of November. And it's now approved for individuals that have relapsed refractory NPM1 mutated AML. So this was based on data from the COMET 001 study, just looking at this in the relapsed refractory setting. These were individuals that ultimately got up to ziftomenib 600 once daily. And again, you can see here that the median duration of response, small, sorry, but it's on the order of about 4.6 months. And the median overall survival with just single agent treatment was about 6 months as well. Generally, the toxicity is quite well. Sometimes we do run into issues, again, with differentiation syndrome. About a quarter of patients that got drug on this trial had that. Sometimes patients can develop actually itching. So we've had a number of patients on our other investigational frontline trials that do develop these itching or pruritus type symptoms. And oftentimes these are treated with topical therapies, but are a known side effect of the drug. So we have a patient here. This lady is 74 years old and looks like she has a diagnosis of an NPM1 mutated AML. It looks like she relapsed here after prior HMA venetoclax therapy. And again, we know that she's NPM1 mutated, FLT3 negative. And so the question really here is, what is the next line of therapy? So, it's an interesting question. And again, I think it gets to this fact here of what is the patient's goal? So she's 74. Again, this might be somebody that if she's a fit 74 with really good performance status and has relatively low level disease burden, with no other big comorbidities, she would be someone I would consider. If we can get her into a complete remission, we can then consolidate that remission with a curative allogeneic stem cell transplant. And so the question becomes, what type of therapy would be best to try to get her into that for? And I think it really depends on what the nature of the relapsed leukemia is. So for example, for a situation like this, if they're failing venetoclax, it is a reasonable expectation to think maybe they have more of a monocytic type phenotype. And particularly if they have other mutations like RAS pathway mutations, it could be very challenging to then get these patients back into a CR. So there would be a strong consideration here to maybe doing a regimen like a cladribine-based approach. So doing cladribine, venetoclax, or LDAC therapy if the patient can maybe tolerate an intermediate dose therapy. Or if we felt this patient was a little bit frailer, maybe the goal was not to get to an allogeneic stem cell transplant. Maybe it was to maximize quality of life at home. Certainly, for sure, a menin inhibitor would definitely be the go-to option. Now, the question of which menin inhibitor to use, I think, is still an open question. Very clearly, there has been no comparative head-to-head studies between ziftomenib and revumenib. I don't think that will probably ever happen, to be honest with you. But, I think now with the approval for ziftomenib, if I'm able to get it from the insurance company without a problem and it's at a low cost to the patient, that would probably be the one I would recommend. And one of the major reasons for that is because the side effect profile, particularly the QTC prolongation, does tend to be markedly reduced with ziftomenib as compared to revumenib. And then also just from a patient taking the drug perspective, ziftomenib is dosed once daily as compared to revumenib, which is dosed twice daily. And so I might make a push here for zifto. However, if revumenib is the only one that's going to be able to get covered, also certainly a fine choice. I think any menin inhibitor is better than no menin inhibitor in this situation. And I would also say if you even opted to do more of that intermediate cladribine-based therapy, you could consider adding in a dose-reduced menin inhibitor on top of that if we felt like the patient was able to tolerate it. Again, trying to get the patient to a CR to get them into a transplant because we know MRD negative remissions are much better than MRD positive remissions going into reduced intensity transplant. So I think that's how I would approach that case. And then, oh yes, trial. So I guess the other thing too would be considering, if we had trials available. Certainly, if we had a trial that involved a combination strategy with a menin inhibitor, I think that would be a great option for this patient. If not, I think it'd be reasonable to try a menin inhibitor. And then, if they're still in a relapsed or refractory state, consideration of a clinical trial if they're interested. So in your experience, what is the specific role of oral hygiene in mitigating side effects and enhancing outcomes for hem-onc patients, specifically considering its effects on their comorbidities? Yeah. So this is a huge issue and oftentimes can be overlooked. And so, the issue you're alluding to is this concept called mucositis. And so this is a problem we certainly run into with folks that get high intensity chemotherapy like 7+3, and certainly an issue that we run into with allogeneic stem cell transplant, specifically if they get, as a part of their conditioning regimen, a drug called melphalan. So it can be certainly problematic. It can lead to, number one, quality of life issues because their mouth hurts. It also can affect their throat. So what happens is they stop eating and drinking because it's quite painful. And so, as you can imagine, patients start to decompensate if they don't get adequate nutrition, specifically through an oral route here. Same thing happens with transplant. We know that nutrition is a very important aspect for transplant. We have to optimize nutrition throughout their conditioning and also post-transplant. And so it's something that really has to be thought of. The other piece of it too is that the mucositis can be that significant that it could limit them from taking the pills, right? And so it actually limits them from getting their leukemia treatment, which is obviously problematic. So at least in my practice, I'm quite cognizant of this fact. So for all of my patients that I transplant, I actually have a long discussion with them, both in the clinic and then when I see them on the floor, to tell them that they have to have really good oral hygiene care. So they have to be able to rinse their mouth out, make sure things are clean, let us know if they're having any types of symptoms of mucositis, because we'd obviously want to be proactive to give them topical agents and even sometimes topical steroids, because again, we want them to be able to eat, drink, and swallow pills so that they have good outcomes. So yeah, really important point. And it's mostly a function of high intensity chemo and then some of the preparative regimens we use with transplant.